Hello, dear classmates and professor. I hope you are as ready as I am to start a discussion of my assigned medical discourse topic. We're in this together, so let's respect and support each other. To make our virtual classroom a healthy and productive environment, let's keep this in mind. Classroom reminders: we need to remember and follow these simple rules during class. Online etiquette: we need to practice proper behavior and good manners in our online classroom. My assigned topic is allopurinol hypersensitivity syndrome. Let us define first what is allopurinol. Allopurinol is a medicine used to lower levels of uric acid in your blood. If you produce too much uric acid or your kidneys do not filter enough out, it can build up and cause tiny, sharp crystals to form in any around your joint. Allopurinol is used to treat gout and kidney. What is hypersensitivity? Hypersensitivity, also called hypersensitivity reaction or intolerance, refers to undesirable reactions produced by the normal immune system, including allergies and autoimmunity. So what is allopurinol hypersensitivity syndrome? It is a severe form of cutaneous adverse reaction, is associated with significant mortality and morbidity. DHS is a serious adverse systemic reaction that usually occurs after a 3 to 6 week exposure to certain drugs. Drugs implicated include anticonvulsants, allopurinol, and sulfonamides. Allopurinol hypersensitivity syndrome is caused by renal insufficiency. It is characterized by the presence of fever, skin rash, and systemic involvement such as liver, kidney, pulmonary, cardiac, eosinophilia, fatal hypersensitivity reactions. It includes drug rash with eosinophilia and systemic symptoms, Stevens-Johnson syndrome, and toxic epidermal necrolysis. So let's proceed in the epidemiology. The annual incidence of allopurinol hypersensitivity increased from 3.7 per 1,000 new users in 2005 to 6.12 per 1,000 new users in 2011 and showed an overall incidence of 4.68 per 1,000 new users. The study done by Paliza and Rabe showed 486 of cutaneous drug hypersensitivity reaction among inpatients at the University of Santo Tomas Hospital in the Philippines from January 1985 to June 1992, which showed exanthematous form as the most common cutaneous adverse drug reaction. The algorithm devised by Kramer et al. Was adopted for more objective reporting of the culprit drugs of the cutaneous reactions.
In this video, we're going to talk about DRESS syndrome, which stands for drug reaction with eosinophilia and systemic symptoms. It's a potentially life-threatening drug-induced hypersensitivity reaction that occurs 2 to 6 weeks of commencing a new drug. It is characterized by skin eruption, looking like a morbilliform rash, hematological abnormalities, such as atypical lymphocytosis, eosinophilia, hence the name, and internal organ involvement, including the lungs, liver, kidneys, as well as other organs not mentioned. The pathogenesis involves a delayed hypersensitivity reaction to a drug and is more characteristic of a type 4 hypersensitivity reaction where the T cells, the immune cells, play an important role. There is also evidence of reactivation of dormant viruses during the infection, such as Epstein-Barr virus, EBV, and human herpes virus 6 and human herpes virus 7. The latency between drug exposure and onset of symptoms is considerably longer in DRESS than in most drug eruptions. The clinical presentation includes fever, malaise, lymphadenopathy all around the body, and eruption of a morbilliform rash that evolves differently but occupies more than 50% of the body's surface area. And here is an example of someone with a morbilliform rash. People with DRESS can also develop swelling of the face called facial edema, and so DRESS is sometimes mistaken for an allergic reaction like anaphylaxis. Other features depend on organ involvement. So we have lung involvement in DRESS, and this is quite non-specific but can include pleural effusion as well as pneumonitis. Liver involvement is common and is usually asymptomatic with some liver derangement. However, other features can include jaundice and hepatomegaly and worse, liver failure. Kidney involvement can also include acute interstitial nephritis. The cause and culprit is usually a new drug, commenced 2 to 6 weeks prior to the manifestation of symptoms. Any drug can really cause DRESS, but the most common drugs known to cause it include anti-epileptics such as carbamazepine, lamotrigine, phenytoin, as well as allopurinol. Other drugs include antipsychotics, sulfonamides such as sulfasalazine, as well as vancomycin. Now let's talk about the pathophysiology of DRESS in a bit more detail. Now there's a lot of theories behind this and different causes, etiologies as to how the immune system responds to a drug. There's a metabolism to haptogenic form theory, and it's where a drug is known as a prohaptin, and when it's metabolized by the liver, it becomes a haptin. Now, the haptin, which is usually safe, does not do much, but it may bind to certain proteins termed carrier proteins from different parts of our body. Now, when they bind, they form a haptin carrier protein complex, and this complex can now be detected by antigen-presenting cells, such as macrophages. The antigen-presenting cells will pick this complex up and then express a component of this protein haptin complex on an MHC class II molecule. Similarly, circulating B cells, which are also antigen-presenting cells, can bind and detect this haptin carrier protein complex, take it in, process it, and then express its component on a MHC class II molecule as well. Antigen-presenting cells travel to the lymph nodes where they then activate T helper cells. Now, T helper cells are CD4 cells because they contain the CD4 receptor, which together with the T cell receptor help identify the MHC class II molecule as well as the component of the drug peptide. The T helper cells are activated by interleukin 12, telling it to become T helper 1 cells. The T helper 1 cells are triggered by interleukin 12, and their further differentiation and activity by interleukin 2, which are released by the T helper cells themselves. T helper 1 cells stimulate the cell-mediated immune response by activating macrophages with interferon gamma and TNF-alpha. Macrophages, which are activated, are primed to attack the haptin protein complex presented by the antigen-presenting cell initially. Now, this haptin carrier protein complex can be anywhere in the body. Regardless, the activated macrophage will attack and, as a side effect, causes tissue inflammation in various areas of the body via TNF-alpha, interleukin 1, and interleukin 6. T helper 1 cells promote the cell-mediated immune response by also stimulating T killer cells, also known as CD8 T cells. CD8 T cells target cells which have interacted with the drug peptide and will kill it, essentially further causing inflammation, tissue inflammation, as a side effect. This mounting of immune response is what happens in DRESS syndrome. The first theory we looked at was one called the metabolism of haptogenic form. There's also another theory called the direct haptogen theory, whereby the drug is not metabolized, but is carried by a carrier protein directly. The carrier protein drug complex is identified again by antigen-presenting cells mentioned earlier, such as the circulating B cells, the monocytes, the macrophages. And this will again trigger the cascade of events we talked about, leading to T helper 1 cell activation. The final theory is the PI theory, standing for the pharmacological interaction with immune receptors theory. The PI theory or concept postulates that some drugs that lack hapten characteristic can bind directly and reversibly to immune receptors and thereby stimulate the cells. Here you can see that a drug binds directly onto the T cell receptor. The T helper cell can then be stimulated. Or the drug binds to MHC class 2 receptors directly, which in turn will stimulate T helper cells via interleukin 12. The immune response mounted from the drug will cause tissue inflammation to different areas of the body, including organs such as the liver, kidneys, and lungs. Unique to DRESS is that the immune response mounted can trigger the reactivation of dormant viruses, such as Epstein-Barr virus and human herpes virus. The theory here is that the cytokines produced in the inflammatory response, such as TNF-alpha, interleukin-1, and interleukin-6, will stimulate the immune response. Some viruses actually stay dormant in these immune cells, so when the immune cells get stimulated, the virus becomes reactivated. The other idea is that antigen-presenting cells, such as B cells, can have latent viruses inside them chilling out. The hapten carrier protein complex we learned about earlier is recognized by the antigen-presenting cell. The antigen-presenting cell is stimulated, and the virus particles that were latent inside them can be reactivated. Thus, the antigen-presenting cell will incorporate part of the virus particles with it, expressing it on an MHC class 1 molecule together with the drug peptide. The stimulated antigen-presenting cells, such as the B cell, will activate the latent Epstein-Barr virus and human herpes virus. The B cell that is expressing the MHC class 1 molecule will be recognized by the T killer cell via the CD8 T cell receptor. And thus the T killer cell will be stimulated and will attack this B cell, and also will cause further tissue inflammation. One of the clinical features of DRESS we have learned is lymphocytosis, elevated lymphocytes in the blood. Lymphocytes, specifically T lymphocytes, as we have learned, play a key role in the pathophysiology of DRESS. The T helper cells and T killer cells are known to produce a special interleukin, interleukin 5. And interleukin 5 is a key cytokine for eosinophil survival, proliferation, and activation. So a lot of interleukin 5 secreted by these lymphocytes will cause eosinophilia, a hallmark of DRESS, and plays a key role in the pathophysiology as well. Eosinophils are circulating granulocytes involved in the host defense, normally against parasites, bacteria, viruses, as well as in allergic reactions. In DRESS, eosinophils infiltrate different organs because of chemokines which attract them into these sites. Here, the eosinophils release their granules, which cause damage to the tissue. Thus, in the liver, hepatocytes, it can lead to hepatitis, or worse, liver failure. In the cardiomyocytes of the heart, it can lead to myocarditis. And the most dangerous involvement in DRESS patients is caused by heart eosinophil damage. In the pulmonary system, the release of these granules can lead to interstitial pneumonitis. In the kidneys, interstitial nephritis. And in the skin, you get the development of a morbilliform rash. Again, the eosinophils infiltrates these organs because these organs release chemokines such as eotaxin and TOC, which attract the eosinophils to the area. So that was the overall pathophysiology of DRESS and the different theories as to how the immune response become activated and mounted. The most important challenge in DRESS syndrome is early recognition of the condition and immediate withdrawal of the offending drug. Failing to do so often proves crucial, leading to unwarranted morbidity and mortality. Treatment also involves steroids, topical steroids for mild skin manifestations, or more commonly, high-dose oral or intravenous steroids with organ involvement or critically ill people. Intravenous immunoglobulin is a possible alternative. Steroids are usually weaned over a course of 6 to 8 weeks. So in summary, DRESS is a delayed hypersensitivity reaction to a drug that was commenced 2 to 6 weeks prior to symptomology. Treatment involves steroids.
The treatment of this is drug discontinuation, supported treatment, example with antihistamines, and sometimes desensitization. Medical treatment. Treatment is with IV and acetylcysteine and steroids. Severe allopurinol hypersensitivity syndrome is more likely to occur in patients with renal insufficiency, those who are taking a thiazide diuretic, and those started on allopurinol at a dosage of 300 mg per day. For the nursing intervention, in assessment, history taking in allergy to allopurinol, blood crushes, liver disease. In physical, skin lesions, color, and orientation. Interventions, administer drug following meals. Drink 2.5 to 3 liters a day. Check urine alkalinity. For warnings, discontinue drug at first sign of skin rash. Severe to fatal skin reactions have occurred. Instruct the patient to take drug after meals. Find time to recharge and engage in offline activities. Find balance and make time for your hobbies as well. Teach patient to avoid over-the-counter medications. Many of these preparations contain vitamin C or other agents that might increase the likelihood of kidney stone formation. For my last slide, which is prognosis, mortality from allopurinol hypersensitivity syndrome may reach 25%. The main causes of death are liver or kidney failure, sepsis, gastrointestinal bleeding, and skin exfoliation. Treatment includes discontinuation of the offending drug and supportive care. Hello, dear classmates and professor. I hope you are as ready as I am to start a discussion of my assigned medical discourse topic. We're in this together, so let's respect and support each other. To make our virtual classroom a healthy and productive environment, let's keep this in mind. Classroom reminders: we need to remember and follow these simple rules during class. Online etiquette: we need to practice proper behavior and good manners in our online classroom. My assigned topic is allopurinol hypersensitivity syndrome. Let us define first what is allopurinol. Allopurinol is a medicine used to lower levels of uric acid in your blood. If you produce too much uric acid or your kidneys do not filter enough out, it can build up and cause tiny, sharp crystals to form in any around your joints. Allopurinol is used to treat gout and kidney stones.